All right, so we're going to jump right into this deep dive today, and we're going to be looking at Crohn's disease and ulcerative colitis.
Sounds good.
And we've got an interesting specimen today. It's a subtotal colectomy.
Wow, a subtotal colectomy. That is interesting.
Yeah, and it was actually taken out because of Crohn's disease.
Okay, so we're already starting off with something unusual.
Yeah,
Most people think of Crohn's disease as something that you take out the ileum and cecum for, and not a subtotal colectomy.
right, exactly. And we'll get into that a little bit later. But first, let's just orient ourselves a little bit and make sure that we're all looking at the right organ.
Yes.
So if you're handed this specimen in the lab, how do you know that you're looking at a large intestine and not a small intestine?
So the large intestine has some very characteristic features.
Okay.
One of the things that's very prominent is the tinea coli.
Okay, so tinea coli, what is that?
So those are three longitudinal bands of muscle that run the length of the colon,
Okay.
and they kind of pucker the colon and give it these little outpouchings called haustra.
Okay, so we've got these tinea coli and hostra. Are those the only kind of external features that we should be looking for?
Yeah, and then there are these little fat tags that hang off the side of the colon,
Okay.
and those are called appendices epiploica.
Appendices epiploica. Okay, so we've got a tinea coli, we've got hostra, and then we've got these little fat tags hanging off called appendices epiploicae.
Yeah.
Now, one of the things that was noted in this particular case was the presence of pseudopolyp. Can you explain to us what a pseudopolyp is?
So it's not a true polyp. So a true polyp is like a growth.
So they're not true polyps like the kind you see in familial adenomatous polyposis.
A pseudopolyp is really just the residue of normal mucosa that's left behind after all of the surrounding inflamed mucosa has sort of sloughed off.
Oh, okay. So it's kind of like it's withstood the storm of the inflammation.
That's a great way to describe them. It's almost like the surrounding mucosa has just disappeared and left behind these finger-like projections.
Interesting. And is that something that we see in both Crohn's and ulcerative colitis, or is that more specific to one?
Well, we can see pseudopolyps in both, but it's much more common, I would say, in ulcerative colitis. But it's definitely something that you can see in both.
Okay. So we've got these pseudopolyps that are present in our specimen. Let's start working our way from proximal to distal on this colectomy and describe what we're seeing.
Okay.
So starting at the very proximal end, we've got our ileocecal valve.
Yes, that's right.
What is that?
So that's the valve that separates the small intestine or the ileum from the large intestine.
Okay. And what are we seeing there?
Well, in this case, the ileocecal valve looks pretty unremarkable.
Okay.
And there's one other thing that we noticed here.
What's that?
This patient doesn't have an appendix.
Oh, interesting. So it must have been taken out previously.
Yes,
Yeah.
exactly.
Okay, so no appendix. That's interesting. We'll have to keep that in mind as we go through the rest of the specimen. So we've gotten through our ileocecal valve. Now we're moving into the cecum. What's going on there?
So the cecum actually looks pretty normal in this case as well.
Okay.
Nice, healthy mucosa.
All right.
And the same thing with the ascending colon.
Okay, so those first two portions of the colon are looking pretty good.
Yes.
Now, I know that somewhere along the way, things start to change. So where are we seeing that transition?
Well, right around the hepatic flexure.
Okay, so that bend between the ascending colon and the transverse colon?
Yes, exactly, right there. The mucosa starts to look very different.
In what way?
There's a lot of inflammation and ulceration, and
Yeah.
we start to see those pseudopolyps.
Okay, and are they just kind of scattered around randomly, or is there a particular pattern to them?
Yeah, so they're actually pretty diffuse,
Mm-hmm.
and they have this kind of interesting arborizing appearance.
Arborizing.
Yeah, so they're kind of branching out like a tree.
So it's almost like there's this little forest of pseudopolyps growing in the colon.
Yeah, you could say that.
Interesting. So we've got these pseudopolyps, which make us think of IBD. And then there's this other finding that really threw me for a loop when I was reading the report.
What's that?
The stricture, a classic sign of Crohn's disease.
Ah, yes. And that stricture is probably the reason why this patient ended up needing surgery. Strictures can obstruct the bowel and cause all sorts of problems. Right, so a stricture is a narrowing of the colon, and it can be caused by a lot of different things.
Okay.
But in this case, it's really unusual because it's so severe.
Uh-huh.
It was actually really difficult to even open up the colon during the gross examination because the walls were so thickened and fibrotic.
Wow. So this wasn't just like a little bit of narrowing. This was a major blockage.
Yes, exactly.
And so that raises the question, is this really Crohn's disease, or could this be something else?
That's a great question, and it's one that we're going to have to explore further as we continue our deep dive.
Okay, so we're starting to see some hints of why this might be Crohn's disease. But to really understand why this case is unusual, let's compare and contrast Crohn's and ulcerative colitis.
Let's do it. I love a good head-to-head.
Okay.
Oh.
Before we go any further, I need a quick spelling clarification, and I know this might sound silly, but how do you spell Crohn's disease? I always get tripped up by that H.
Don't worry. It's a common mistake. It's Crohn apostrophe S.
Got it. Crohn apostrophe S. All right, round one. Clinical presentations. What are the symptoms that would typically send someone to the doctor?
Well, both conditions can cause abdominal pain, diarrhea, and weight loss. So at first glance, they can be pretty hard to tell apart. But there's one key difference. Crohn's can affect any part of the digestive tract, from the mouth all the way to the anus, while ulcerative colitis pretty much sticks to the colon and usually starts in the rectum.
So Crohn's is like a rogue agent popping up anywhere it wants, while ulcerative colitis is more like a homebody staying put in the colon.
I like that analogy. And that difference in location is one of the main reasons why a subtotal colectomy is unusual in Crohn's disease. We typically see more ileocolic resections where we remove the end of the small intestine and the beginning of the colon.
Okay, now let's talk about fat malabsorption. Which condition is more likely to cause problems with fat absorption and why?
So Crohn's disease, especially when it affects the small intestine, can lead to fat malabsorption because that's where most of the fat absorption takes place.
Makes sense. If the small intestine isn't working properly, then you're not going to absorb fat as well. Okay, so we've got fistulae, knife-like ulcers, fat malabsorption, all pointing towards Crohn's.
Yeah.
What about cancer risk? Which one of those is associated with a higher risk of developing cancer?
So ulcerative colitis carries a higher risk of developing colon cancer.
Okay, so UC is the one to watch out for in terms of cancer risk.
Yes.
That makes perfect sense.
Okay.
Round two, macroscopic features.
Mm-hmm.
What are the key visual differences we see when we examine the affected tissue?
So with Crohn's, you often see what we call skip lesions, patches of inflammation separated by areas of normal tissue. It gives the bowel a cobblestone appearance. Ulcerative colitis, on the other hand, is more continuous. The inflammation spreads from the rectum upwards without skipping any areas.
Ah, so in our case, we saw a clear line of demarcation, which points towards Crohn's.
Exactly. Another key difference is the depth of the inflammation. Crohn's involves transmural inflammation, meaning it affects the entire thickness of the intestinal wall.
It's like comparing a surface scratch to a deep wound. Crohn's is much more aggressive.
You got it. Ulcerative colitis mainly affects the innermost layer of the colon, the mucosa. It's more of a superficial inflammation.
Location and depth. Got it. What else sets these two conditions apart?
Well, think back to those strictures we talked about. They're much more common in Crohn's because of that transmural inflammation.
Ah, right. The deep inflammation causes scarring and thickening of the intestinal wall, which leads to those narrowings.
You're getting it. Now, here's another important point. Crohn's can also lead to fistulas.
Okay, and can you remind us what a fistula is?
Sure, so a fistula is an abnormal connection between two different parts of the intestine,
Okay.
or between the intestine and another organ like the bladder or the skin.
Oh, wow. So it's like a tunnel that forms. That sounds pretty serious. Are fistulas common in ulcerative colitis?
Not really. They're much more characteristic of Crohn's disease, again, because of that deep transmural inflammation. It can actually burrow through the layers of the intestine and create these abnormal connections.
Wow. All right. What about those classic knife-like ulcers that we hear about?
Those are much more typical of Crohn's disease.
Okay, so Crohn's gets the prize for those scary-sounding ulcers.
Yes.
Noted. Okay, so we've covered the macroscopic features. Now let's zoom in and explore the microscopic world. What are some of the key things pathologists look for under the microscope?
Well, one of the most telling signs is the presence of granulomas. These are clusters of immune cells that are found in about 35 to 50% of Crohn's cases, but they're very rare in ulcerative colitis.
So granulomas are like a microscopic fingerprint for Crohn's disease.
Exactly. They're a big clue that helps us point the diagnosis in the right direction.
Fascinating. So we've got these granulomas. What else do we see under the microscope?
Well, a lot of inflammation, of course, but the key is that it's transmural, extending through all the layers of the intestinal wall. Remember, that's a hallmark of Crohn's disease.
Right. It's that deep penetrating inflammation that sets it apart from ulcerative colitis,
Yeah.
which is mainly limited to the mucosa.
Exactly. Under the microscope, we see a heavy infiltration of inflammatory cells, lymphocytes,
Yeah.
plasma cells, macrophages, all swarming the area and causing damage.
It's like a microscopic war zone with all these different cells engaged in battle.
I like that analogy. And it's this chronic transmural inflammation that leads to many of the complications we see in Crohn's disease, like those strictures and fistulas.
Because the inflammation causes scarring and thickening of the intestinal wall.
Precisely. The microscopic examination allows us to see this damage at a cellular level, which gives us a much deeper understanding of the disease process.
So we've explored the macroscopic battlefield, those pseudopolyps, that stricture. And now we've zoomed in to see the microscopic details, those granulomas and the transmural inflammation. It's like we've pieced together a puzzle, right?
Absolutely. And having all these pieces of information allows us to confidently make a diagnosis and guide treatment decisions.
Interesting. Okay, so now let's get back to our colectomy specimen. You mentioned that a subtotal colectomy is unusual for Crohn's.
Yes.
Why is that?
Well, typically when we see Crohn's disease, it's more common to do an ileocolic resection.
Okay, and what does that involve?
So that involves removing the terminal ileum, which is the last part of the small intestine,
Okay.
and the cecum, and sometimes a portion of the ascending colon.
So instead of taking out this big chunk of the colon, they're just taking out that little section where the small intestine meets the large intestine.
Exactly.
Okay, so why did they do a subtotal colectomy in this case?
Well, it all comes back to that stricture we talked about.
Okay.
That stricture was so severe that it was causing a significant blockage.
Mm-hmm.
And it was really the main reason why this patient needed surgery.
So it wasn't just an incidental finding, it was actually causing problems.
Yes, exactly.
Wow. Okay, well, let's talk about how a pathologist would approach grossing a specimen like this. I know there are a lot of different things to consider.
Yes, they're all...
What are some of the key steps?
So the first thing you want to do is measure the bowel.
Okay, so get out your ruler.
Yes, exactly. You want to measure the length of the ileum if it's present, the cecum, the ascending colon, the transverse colon, the descending colon, sigmoid colon, and the rectum.
Wow, so we're really mapping out the entire territory.
Yes, that's right.
Okay, and what about those pseudopolyps? How do we describe those in the gross dictation?
So you want to be as descriptive as possible. You want to note their size, their shape, their distribution, and any other interesting features like that arborizing pattern we talked about.
Okay, so really paint a picture with words. And then, of course, we need to take samples for microscopic examination. How do we decide where to take those biopsies?
So the general rule is to take samples every 5 centimeters in areas that look diseased, and every 10 centimeters in areas that look normal.
Okay, so more frequent sampling in the areas where we see those pseudopolyps and that inflammation.
Yes.
What about that stricture? Do we need to sample that as well?
Absolutely. You want to take multiple sections through the stricture to see how much fibrosis there is and to look for any other interesting features.
Okay, so the stricture is getting special attention.
Yes.
What are some of the things that we need to keep in mind when we're grossing a specimen with a fistula?
So the first thing is to identify all of the fistulous tracts.
Okay, so we're mapping out the tunnels.
Exactly.
Okay, and then what?
And then we need to describe them carefully, noting their location, their size, whether they're open or closed, and whether there's any associated abscess formation.
Abscess formation? What's that?
So an abscess is a collection of pus,
Okay.
and it can form around a fistula if the fistula gets infected.
Oh, that doesn't sound good.
It's not.
Okay, so we're looking for abscesses, and then what else?
And then we need to take biopsies from the fistula tract itself
Okay.
and from any surrounding inflamed tissue.
So we're really trying to get a comprehensive look at what's going on in that area. What about the areas where the inflamed tissue transitions back to normal? Are those important to sample?
Yes, definitely.
Okay.
We want to see what's happening at that interface between the diseased tissue and the healthy tissue.
So even those seemingly normal areas can hold valuable clues.
Exactly.
What about lymph nodes? Why are those important in a colectomy specimen?
They can help us stage any cancers that might be present.
Okay, so we're looking for both inflammation and malignancy in those lymph nodes.
Exactly.
Well, it sounds like we've got our work cut out for us with this specimen.
We do.
So what happens to this specimen once we're done describing it and taking our samples?
It goes to the histology lab where it's processed and embedded in paraffin wax.
Okay.
And then it's cut into very thin sections that are placed on glass slides.
Okay.
And then those slides are stained with special dyes that allow us to see the cells and tissues under the microscope.
So that's where the real detective work begins.
Yes, that's right.
Well, I am definitely intrigued to see what the microscope reveals in this case, but I think we need to take a quick break before we get into that, so we'll be back in a few minutes to continue our deep dive.
Sounds good. And we are back.
I mean, we can see a lot with the naked eye, but the microscope really allows us to zoom in and see what's happening at a cellular level. All right, let's put on our virtual lab coats and head over to the microscope.
Sounds good to me.
So we've got our slides all set up. What are we looking for?
Well, the first thing we want to do is confirm the diagnosis.
Okay, and how do we do that?
So remember those classic features of Crohn's disease that we talked about?
You mean like those skip lesions and the transmural inflammation?
Exactly. We're going to be looking for those under the microscope.
And hopefully some granulomas too, right?
Yes. Granulomas are a hallmark of Crohn's disease. So finding those would definitely support the diagnosis.
Okay, so we're scanning our slides looking for those key features. What else are we looking for?
Well, we also want to assess the severity of the inflammation.
Okay.
So we're looking at how deep the inflammation extends into the bowel wall and how much damage there is to the crypts.
The crypts, those are the little glands that line the colon.
Yes, that's right.
Okay. And why is it important to assess the severity of the inflammation?
Because it can help us predict how the disease might progress.
Okay.
And it can also guide treatment decisions.
So the more severe the inflammation, the more aggressive the treatment might need to be.
Exactly. And that's where we can confirm the diagnosis and look for any subtle features that might help us understand the disease better.
Okay, what about that stricture we saw in gross examination? Are we going to be able to see that under the microscope?
Yes, definitely we can look at the stricture microscopically to see what's causing it.
Okay.
So is it just inflammation and edema?
Okay.
Or is there a lot of fibrosis?
Fibrosis, that's the thickening and scarring of the tissue.
Exactly. And that can make the stricture more difficult to treat.
Okay, so we're looking at the stricture to see how much fibrosis there is.
Yes.
Now, one of the things that we always have to be on the lookout for in patients with IBD is dysplasia.
Right.
Can you explain what dysplasia is and why it's so important?
So dysplasia is a precancerous change.
Okay.
So it's not cancer yet, but it's a warning sign that cancer might develop in the future.
And is that something that we can see under the microscope?
Yes, we can.
Okay, so we're carefully examining our slides, looking for any signs of dysplasia.
Exactly.
Now, I know that sometimes the lines between Crohn's and UC can get a little blurry,
They can, yeah.
and we end up with these indeterminate cases.
Right.
What are some of the challenges in diagnosing and managing those patients?
Well, it can be really difficult to tell the difference between Crohn's and UC just by looking at the biopsies.
Okay.
Sometimes we need more information like the patient's clinical history, their symptoms, and the results of other tests like imaging studies.
So it's really a team effort.
It is.
We need the gastroenterologists,
Yeah.
the pathologists, all working together to figure out what's going on.
Exactly.
Okay, now you mentioned microscopic colitis earlier. Can you explain what that is and how it's different from Crohn's and UC?
Sure. So microscopic colitis is a condition that causes chronic watery diarrhea,
Okay.
but it's called microscopic colitis because the colon looks normal during a colonoscopy.
Really? So you can't see the inflammation with the naked eye?
Not usually, no.
Wow. So how do you diagnose it then?
You have to take biopsies and look at them under the microscope.
Okay, and what do you see under the microscope?
So there are two main types of microscopic colitis.
Okay.
There's collagenous colitis
Mm-hmm.
and lymphocytic colitis.
Okay, and what's the difference between those two?
So in collagenous colitis, there's a thickening of the collagen layer beneath the surface epithelium.
Okay, so it's like a thickening of the lining of the colon.
Yeah, you could say that.
Okay, and what about lymphocytic colitis,
In lymphocytic colitis, there's an increase in the number of lymphocytes.
which are a type of white blood cell?
Yes.
Okay, so those are the two main types of microscopic colitis.
Yes.
And how is that different from Crohn's and UC?
Well, microscopically, Crohn's and UC are both characterized by more severe inflammation.
Okay.
And they often have other features like ulcers, granulomas, and crypt distortion.
So microscopic colitis is kind of like a milder form of IBD.
You could say that.
Okay, well, that's good to know. Now, before we move on to the microscopic features of this case, I just
Yeah.
wanted to touch on one more thing that came up.
Okay.
Diversion colitis.
Oh, yes.
What is that all about?
So diversion colitis is an inflammation that can occur in a segment of colon that's been surgically bypassed.
Okay, so if you have surgery to remove part of the colon or to reroute the fecal stream, you can develop inflammation in the bypass segment.
Exactly.
And why is that?
Well, we don't know for sure, but it's thought to be related to changes in the gut microbiome.
The gut microbiome, that's the trillions of bacteria that live in our intestines.
Yes.
Okay, so if you change the environment in the colon,
Right.
you can disrupt the balance of bacteria,
Exactly.
and that can lead to inflammation.
Yes.
Okay, so diversion colitis is something to keep in mind in patients who have had previous colon surgery.
Definitely.
Well, I think we've covered a lot of ground today.
Well, I think one of the most important takeaways is that Crohn's disease can be really unpredictable. It doesn't always follow the textbook. We tend to think of Crohn's as affecting the ileum and the colon, but in this case, the disease was primarily localized to the transverse colon, which is why the patient needed a subtotal colectomy rather than the more typical ileocolic resection.
Right. So it's a good reminder that every case is different,
Hmm.
and we need to be prepared to think outside the box.
Absolutely. And I think another important lesson from this case is the value of careful macroscopic examination. Those pseudopolyps and that stricture were really the key clues that pointed us towards Crohn's disease.
Because it's so characteristic of Crohn's, right?
Exactly. They're not pathognomonic, meaning they can be seen in other conditions, but they're certainly suggestive of Crohn's. And in this case, they help to guide the diagnosis.
And then, of course, we had the microscopic confirmation with those granulomas.
Right. Those were the icing on the cake. Seeing those granulomas under the microscope really solidified the diagnosis.
So it's really a combination of macroscopic and microscopic features that helps us to make the right diagnosis.
Precisely. It's like putting together a puzzle. Each piece of information adds to the overall picture.
And speaking of the microscopic world, we talked about how part of grossing the specimen involves looking for fistulas. We've gone from the macroscopic features of this colectomy specimen all the way down to the microscopic detail.
And we've talked about some related conditions like microscopic colitis and diversion colitis.
Exactly. And we've even discussed the challenges of those indeterminate cases.
It's been a really comprehensive deep dive.
It have. I've learned a lot, and I hope our listeners have too.
Me too.
So to wrap things up, I just want to emphasize that IBD is a complex group of disorders.
It is.
But with the right team of doctors and the right treatment plan, most patients can live full and active lives.
Absolutely.
So if you're listening and you have any concerns about IBD, please talk to your doctor.
Good advice.
They can help you get the diagnosis and the treatment you need.
Exactly.
Well, that's all the time we have for today. Thanks for joining us on this deep dive into Crohn's disease and ulcerative colitis.
It's been a pleasure.
Until next time, keep those minds engaged and stay curious.